So I'm going to talk about the immune system and how it's affected by CLL. It's an area that I'm really interested in. I spent 4 years doing a PhD in immunology, both in Southampton and then at in Houston in the States, at the MD Anderson Cancer Center. So I've got a big interest in this, so I'm going to run through. This is our hospital, by the way, for people that don't know Bournemouth. It's quite pretty, next to the lake. This is our new cancer centre, which we're very proud about. It took us many years to fundraise to build that, and I think we've got some lovely facilities now. So, really, I think looking at the immune system, it is a double-edged sword, and I think there are two big problems that we can face in CLL with the immune system. Either it can be out of control, and actually start attacking our own tissue, and that's something we call autoimmunity, and that's something that happens with all folk with CLL to lesser or greater extent, is that it's not working as it should do. And that's something that in medical jargon we call immunodeficiency. And this is a picture of 1912 of Niagara Falls, when it froze over, and people actually were silly enough to walk across the top. So I was quite impressed with that photo. So there is a bit of overlap really with Ram's talk. I'm just going to recap some things just because I think it's quite a complicated area. I find it complicated as a humble physician. So it's useful to go over it again. So this is really what I'm going to talk about, as just listed here, which I can let you read. And I just want to really focus on what the immune system is. It's a bit of a sort of nebulous term, and I think people don't really understand it. This is the immune system organ, if you like. And I explain it to people that we have a network of plumbing, and where these vessels meet, that's where we have our lymph nodes. Tends to be in the bendy bits of the body, so in the neck, under the arms, tops of the legs. And these little buttons here, or lumps, those are lymph nodes, or glands, as we explain them in sort of lay terms. There's the liver, the spleen, that's part of the immune system as well. And CLL is a liquid tumour, so it moves in the blood, it can jump, cancer cells can jump into the immune system through the lymphatic system. So when people talk about CLL, it's not like other cancers. I think sort of lay public's very used to thinking about a cancer, and if you've got, for instance, lung cancer, it's spread to the bones, or it spreads somewhere else, that's bad news. CLL is totally different because it's everywhere to start with. So the way to think about it, this is one entire organ. So it's just one organ that's affected. And what are the immune cells? Can everybody hear me, by the way? Okay, yeah, good. So the bone marrow is the factory in the body, as we've heard before, and it's the factory that makes all of the blood cells. The immune cells are the white cells. We have 5 different types. 4 of them on this side, and these guys are really ancient actually. This is part of what we call the innate immune system, and that stems back to it's over many millennium has been developed in invertebrates. Many will have this. This bit, these guys, the lymphocytes, the very clever bit, which we call the adaptive immune system, and it's only vertebrates that have these. CLL, obviously you get the B cells and the T cells, and as you've heard, CLL is derived from B cells. This is another slide, which is sort of a variation of the theme that Lara showed. So it starts off life in the bone marrow. This is the early baby B cells. And then they go through different stages of maturation. And eventually, they mature into something called a plasma cell or a memory B cell. The plasma cells are the antibody-making cells, and the memory B cells have an antibody, which is stuck on the surface of them, or we also call B cell receptor, or the immunoglobulin. It gets very confusing because doctors call this something different. Every single doctor you meet gives it a different name. So no wonder we get confused. Now, when any of these different stages, if a cell at one of these stages undergoes a change and has a malignant change, you then get a cancer that's derived from each of those different stages. So the really early baby ones go into a form of acute leukemia, and then you can see the CLL we don't have all the answers, but we think there are these two stages, and Lara just touched on this a bit, and this is to do with the surface immunoglobulin or surface antibody, whether or not it's got some of these changes and the mutations we've talked about in the V genes. So they get stuck at the stage of the malignant change. So each of the baby cells of a CLL cell will have the same flavour of antibody on the surface. So it's unique to everybody's individual disease. So this is just really to talk about what can go wrong. And so when the immune system is out of control and it's due to the antibodies, so antibodies are very good. They're a really important part of our immune system that we all have, and they fight infection. And we have millions and millions of different types of antibodies that fight different types of infection. But they can also be directed against our own tissues and cause problems. And this can happen in CLL. So we can get a hemolytic anemia. This is something called a cold autoimmune hemolytic anemia. And you can see that all the red cells here are all clumped together. And it's because an antibody that reacts in the cold. You can get a weird thing called pure red cell aplasia. And that's when you have an antibody that's directed against the very baby red cells. And so they're not made in the first place. People get very anemic. ITP, that stands for I, for immune. T for the thrombocytopenia, which is medical jargon, you don't have enough platelets, and the purpura is because it doesn't actually show very well here, but you get a very typical platelet rash. So when your platelets are less than 10, they should be 150 to 400 is the normal range. If they're less than 10, you get this typical rash, and it looks as though somebody's taken a pin, tiny pin, and stabbed you multiple times in your shins. So anybody who's had ITP and have very low platelets will recognise this, because it's quite a telling sign that people can get. You can get some really weird and wonderful autoimmune complications. Sometimes we make antibodies that destroy the neutrophils, so that's a reason why people can be neutropenic when they don't have any neutrophils. And this is a bit of a weird one. I've had patients who have had this complication, and it's basically we have different checks on the immune system, and one of them is a way to turn off the immune system once it's been activated to fight infection, and that's something called the C1 esterase inhibitor. And if you make antibodies that destroy this switch, the immune system's just unchecked and can get carried away, and you can get these weird sort of swellings, and it's something called angioedema. And that's something, and people can get very exaggerated responses to allergic reactions. Of course, it does get a little bit more complicated. I'm not going to spend too much time on this, other than to say that the CLL cell is here. As I've talked about, they can make antibodies that can cause problems. In our hemolytic anemia, actually, it's not the CLL cells themselves that are making the naughty antibodies. In fact, it's sort of small amounts of the healthy B cells that are left, and it's due to the CLL cell is a master regulator, and it's controlling these to making cells they shouldn't, making antibodies they shouldn't. There's quite a lot of work in looking at the B cell receptor. We even know now that some types of CLL, some of the mutations can actually stimulate the CLL itself and cause growth. So there's a lot of work and a lot we can discover about CLL looking at this simple B cell receptor. So I'm just going to talk now a little bit about some of these immune complications. This is hemolytic anemia. What that means, this is what it looks like when we look at somebody's blood under the microscope. So these are all of the red cells. They should be nice and round with the little pales dotted in the middle. When you look here, there's some that are filled in, and that's what we call spherocytes. And these deep blue ones are something called reticulocytes. So the reticulocytes are the baby red cells. So what happens as soon as you break down, so people have antibody stuck on this, and they're broken down, and so then the bone marrow starts working much harder. So that factory goes into overdrive to make a lot more blood cells, the red blood cells, and pushes out more of these baby ones, which are the reticulocytes. So when we look in the lab to do tests, we look for reticulocytes to see if they're increased. LDH, that goes up if you're breaking down a lot of these cells, because that's a gubbins that's inside the red cells. Bilirubin is a derivative of the dye that makes blood red, and that turns people yellow. And then haptoglobin is a protective substance that mops up any loose hemoglobin, which is the dye in the red cells, effectively. People will know that probably when you look at your blood forms, you can see very often we ask for a DAT. That stands for direct antiglobulin test. It's as old as the hills, really, in blood tests. Very simple. What we do is we take the blood. If somebody's got some antibody stuck on their outside of their red cells, which that shouldn't be there. So normally we don't have antibody stuck on our red cells, but if your DAT is positive, you will. So what we then do is take the blood, and then we've actually made some antibodies that recognise antibodies, which is a bit weird, isn't it? But these are the antibodies that are antiglobulin. So globulin is another name for antibody. And what happens, so those antibodies recognise these antibodies, sticks all the blood together, and you get agglutination. And literally all the lab does, they do all of this, and they just look at the tube, and they say, yes, there's red cells are stuck together, you have a positive DAT. So that's essentially what it means. Now, up to nearly a third of patients with CLL do have a positive DAT. That doesn't mean everybody goes on to have a hemolytic anemia, as they don't. So most people have this positive DAT, but the immune system's controlling the naughty antibodies, and it doesn't go on to cause this. This is really what we see in a hemolytic anemia. So in anemia, you have too few red cells. This is somebody who's jaundiced. If you look at the whites of the eyes, that's the best way to look for jaundice. They're obviously quite yellow. It's quite striking looking at the difference here. And you do see people. If good-going jaundice is very obvious. The reason that we get symptoms from anemia is that the red cells carry oxygen to tissue, so we can't get enough oxygen to the tissues we need. It makes people very tired. Leads to breathlessness. Exercise tolerance can drop off very quickly. And the typical symptoms, people say they get ringing in the ears or palpitations. A good place to look for anemia is in the nails, in the nail beds, so that's a good place to look. So, in fact, although around 30% of people have this positive DAT, only up to about 10 to 20% of people with CLL will go on to develop an autoimmune hemolytic anemia. That's the abbreviation for that. It is more likely with advanced stage, so if you've got more advanced CLL, you're more likely to have this problem. It is more likely with some of our risk groups, so people who've got some of these higher risk groups to need treatment are more likely as well. And one of the catches, it's very, very difficult. I've told you sort of the basics, how we look for it in the lab. Actually, it's quite a challenge in CLL often, and I'll go on to explain a bit more in a moment. And you can really get it in two situations. Either it's by itself, and actually people don't need treatment for their CLL. They just need treatment for their hemolytic anemia. Or you can have a situation where the CLL is causing trouble, and you need to try and target both things at once. So we've been involved, Rolata and myself, in writing the national guidelines on CLL, and I did the section with Claire Deirdre on autoimmune hemolytic anemia. And there are some things we need to watch out for. So I think a lot of doctors, and the junior doctors perhaps, sometimes miss hemolytic anemia in folk because you don't have the full spectrum of all the signs that we'd normally see. So what we say is that really just be vigilant. So that's why I've got a big alert thing there. So if you suddenly get a quick drop in hemoglobin, so that's the measure whether you're anemic or not, without any obvious other cause. So if you haven't suddenly bled, and there's nothing else obvious why you've suddenly become anemic, my question always is, could you be having some hemolysis and breaking down these red cells? So to diagnose it, we just need one feature. LDH, of course, if your CLL is more active, the LDH can shoot up anyway, so that doesn't always help. The bilirubin, people, if it's quite subtle and it's happened over a long time, people aren't always that jaundiced, and you don't often have, sometimes you don't have a very high bilirubin, which is the dye that makes people yellow. So yes, I think just be vigilant and be aware. So if we're going to just treat the hemolysis, and people don't need treatment for the CLL, it's treated the same way as for people having an autoimmune hemolytic anemia without CLL. So there's some very general important things. People get folate deficient because there's quite a lot of it's a vitamin that's in the red cells, and as you're breaking down these red cells so much, you can lose folate. So that's really, really important. You've got to have folic acid. We use omeprazole a lot because the first line treatment is steroids. That can irritate the lining of the gut, so you've got to have something to reduce the acid. So we need a proton pump inhibitor or a similar drug. So Zantac is another drug that you can use. People are much more prone to getting blood clots. So when you're actively breaking down red cells, because you can release different substances in the red cell, makes your blood much more likely to clot. So you need a blood thinner if you've got active hemolysis. And again, the osteoporosis protection comes back to the steroids. Being on steroids for a number of months puts you at big risk for osteoporosis, so you need to have some protection. Then that will work in the majority of people. It doesn't work for everybody. Our second line treatment is rituximab. And if that doesn't work, then we've got some of these other drugs here, which is what we call immunosuppression. So it's just to dampen the immune system, keep it under control. And we do still use splenectomy. People who've got complex disease, so that means they've got their CLL needs treating at the same time as having hemolytic anemia. It's the CLL driving the problem, so we need to use the most effective drug that's going to be right for them, so personalised treatment to treat both at the same time. Now this is a very complicated slide, but it's really just to highlight that you can get some drugs will actually precipitate a hemolytic anemia. So if you look at the very early study that David Osier led from Bournemouth, and it's looking at comparing chlorambucil with fludarabine and the combination of the two, actually both you get an instance up to 11 to 12% of people could develop a hemolytic anemia. So single agent chemotherapy drugs are not very good for this. So those do. People always think of fludarabine as being a risk, but actually chlorambucil can do it as well. It's much rituximab, because we know that's a treatment that's very good for treating hemolysis. It's quite protective together with chemotherapy. So much lower rates with FCR. Good news is that some of the newer drugs, so with ibrutinib, we've got very, very low levels, which is very encouraging. Some people have a really explosive hemolytic anemia that's out of control. If it's life-threatening or it's precipitated by one of the drugs, fludarabine, we wouldn't recommend using those drugs. There's an alternative, luckily, which is a very good combination. It's with rituximab and then cyclophosphamide and steroids, and that works extremely well, even with people who you're having to transfuse daily to get to keep their hemoglobin at a safe level. There are other alternatives, and ibrutinib you can use as well. Renata's going to talk a lot more about that later on. So ITP, so that's the immune thrombocytopenia purpura. So your platelets are destroyed by a bad antibody. It's not quite as common, so that's the rate. Up to 30% of people who have ITP actually have also had either at the same time have a hemolytic anemia or at some point have had a hemolytic anemia, and that's this weird thing called Evans syndrome, which is a really tricky condition to treat. Treatments are very similar to hemolytic anemia. You can see the list. One that's really important, though, is intravenous immunoglobulin. So that's an antibody treatment, and we use that as an emergency treatment. So if your platelets were less than 10, first thing that would happen, you'd have that, and at the same time, we'd start steroids. We've also got a whole new family of drugs called TPO agonists, and that stands for thrombopoietin receptor agonists, and they're things like elthrombopag and romiplostim, and what they do is they really drive your bone marrow to make more platelets, because we know that there is a problem that the platelets not being made as quickly as they should do, and we've got the experience of those and using those in folk with CLL. Splenectomy is very effective. It's not such an effective treatment for Evans, though, so that's my only word of warning. Really delightful slide. I was very pleased to see that everybody has got a hand gel on their table. Just a change of tack now. This is looking at the other side when the immune system is damped. And I'm going to talk about some of the important infections and really what we can do to protect ourselves against them. Flu is a really bad news. We all need to be very vigilant about it. We've had a bad flu season on the south coast this year. We've even still been getting a few cases in the last few weeks. Most people haven't had flu. People who say they've got flu, it's generally a sort of a respiratory virus or a bit of a cold. When people have flu, they are very, very sick. We do have mortalities from people who are completely healthy, have no problem with their immune system, and every year we lose a couple in Bournemouth Hospital with people who've got a normal immune system. So the symptoms to be vigilant for. Sometimes it starts with a bit of diarrhea and vomiting, actually, so you can get with gastric side effects. Extreme fatigue is another one. Obviously the fever, but you don't always have it. And sort of runny nose, sore throat, really bad muscle ache, joint ache. So that's myalgias, muscle ache, arthralgias, joint ache. It's spread by droplet spread, so infected surfaces. So that's why I would say my top tip of the day actually, invest in a little jar of one of these hand gels, take it with you. Don't eat or drink anything when you're out and about without washing your hands ideally. If you can't wash your hands, use the hand gel. It's very effective. This is just a bit of a scary slide to say that it's not just the original turn of the century Spanish flu. I mean, that was a shocker. It killed nearly, if you look at the numbers, nearly more than the First World War. I mean, absolutely unbelievable numbers. But we are every year, 10 years or so, we are getting pandemics. We had the big scare with the swine flu. So this H1N1 is a swine flu strain. We have been picking this up still. What kills people is the superadded bacterial pneumonia you get as a result of the flu. So you do need to see a doctor. I'm going to talk a little bit more about it in a moment, but this is just to say why it's a problem in the CLL. And really, just to go back to basics, we have the B cells and the T cells. The T cells, they kill infected cells. The B cells will be good at protecting any invaders outside the cell, and obviously they go on to make antibodies. We know in CLL that up to nearly half the people with CLL will have low antibody levels at diagnosis, actually, and that does fall over time. CLL can secrete some factors. They're like little mini hormones, something called cytokines, and these are very good at suppressing the immune system. There are two types of T cell, the CD4 and the CD8. CD4, those numbers can plummet with some of our treatments, so things like fludarabine and bendamustine, so we need to have protection and protective antibiotics until they recover to normal levels. And there are some changes with the T cells we get as a result of CLL. So this is just a quick slide to show somebody with CLL over time, and there's IgG, IgM and IgA, and the antibody levels fall with time. This is just to say it gets more complicated. We've got more than just the B cells. We've got these guys called the regulatory T cells, and they control the immune system. We now know that we've actually got regulatory B cells, and there is a school of thought that thinks that CLL is derived from a regulatory T cell, can make these factors that suppress the immune system and causes these problems. So these are important infections. This is shingles. Anybody in the audience had shingles? Yep, it's very, very common in CLL. If you get typical rash, unilateral, you get pain first, go to your GP quickly. You need acyclovir as soon as possible and have that treated. If you get recurrent chest infections, it can lead to some damage in the lungs. This is something called bronchiectasis. So we want to stop this from happening. So we need to vaccinate. So everybody needs to be up to date with the flu vaccine every year, a pneumococcal vaccine, and Haemophilus vaccine was one, should be on there as well. We now recommend that you have 2 types of vaccine, so that's really important. Response to vaccination is impaired in CLL. must not have any live vaccines. So that's completely contraindicated. So you're not allowed the shingles vaccine because that can give you chickenpox. Not allowed yellow fever vaccine. We use protective antibiotics. A lot of the time people are on cotrimoxazole. That's after treatment to protect against a rare type of pneumonia. People who've had lots of problems with recurrent pneumonias, we can use azithromycin as a protective antibiotic. And we also use antibody replacement. So immunoglobulin is just an antibody, and we replace what people are lacking. And there's just some rules about who's allowed access to that. The other thing, so prevention is important to prevent infection. Early detection is important. This is a machine we've got in Bournemouth, and it looks for all these respiratory viruses. It's cheap. It only costs 95 quid a run. Turnaround time's an hour, so we can know very quickly, has somebody got flu? If they have, they can have the treatment. There are tablets that you can be treated for flu to stop it developing into a life-threatening infection. So, oops, I've lost one of my things. This was going to be a photo of Mr. Ehrlich. So, might be coming up. Here he is. Right. So he won the Nobel Prize, and he basically had this idea that the immune system not only fights infection, but it also has a role in fighting, protecting against cancer, something we call tumour surveillance. That's certainly important in CLL. We know, unfortunately, that folk with CLL are more prone to skin cancers and also a little bit more prone to getting other cancers. And that's because the immune system is weaker and your tumour surveillance is reduced. This is my nearly finished. So this is about immunotherapy. And Renata's going to talk a lot more about that. So that's all our treatment now is part of immunochemotherapy. This is, he's the godfather of immunotherapy. It's not a new idea. You can read what happened, but he basically was a surgeon who treated folk with a type of nasty bone cancer, and he noticed if patients had had a severe skin infection, their cancer would regress. And this is where the idea of immunotherapy comes from, and he had some really incredible responses to people. So he injected bits of the bug and got some good remissions. So it went on to allogeneic bone marrow transplant, and what you do with this, we basically are giving somebody else's immune system, and that the immune system recognises the recipient as foreign, and you can get a graft versus leukemia effect, and that's why it's an effective treatment. We do still transplant some patients. But we've got a whole new type of treatment, which is called these CAR T cells, and it's a modified T cell, which is programmed to read a barcode on the CLL cell or any other B cell tumour. This slide is showing the case of somebody with an acute lymphoblastic leukemia, and it's now a drug that's been licensed because they've had some really remarkable results. This is a quick slide to show what happens. You take blood from people, isolate the T cells, then they have to be grown in the lab and then modified to be reprogrammed to recognize the barcode on CLL cells, and then they're infused again. This is still in the clinical trial stage. It's quite a toxic treatment, so it tends to only be undertaken in a centre who's very familiar undertaking bone marrow transplants, but we have some centres in the UK currently. That's it. Any questions? Yes, and that's because I sort of brushed over it a bit. That basically, it's because we know that in CLL you don't respond very well to vaccinations, and so there's one called Prevnar, and it's called what we call a conjugated vaccine. So it's got something that's a bit more of a stimulus to the immune system. So because the immune system is quite lazy, it's for the pneumococcal vaccine by itself, a lot of people don't react. So the recommendation is to have this really booster, Prevnar, which has this conjugated vaccine first. Now, there are about 23 plus different strains of this particular bug, pneumococcus. So that one's quite limited. It only covers some of the strains, and that's why they recommend start with that one, make the immune system wake up to recognize pneumococcus, and then follow it up with the one that then covers all of the strains. So that's why they're the two vaccines it's recommended. Is CLL a recognised disability? And that sort of leads on to the next question. So I'll read the next question and I'll answer them together. Somebody's on a watch and wait, I don't like that term at all. I never use it. Active monitoring is the term I always use in clinic to everybody. It's not watch and worry. But they're saying they've got a lot of fatigue and it's really debilitating. That's quite a very common problem. Am I entitled to any benefits as a CLL patient? Yes, definitely. In Bournemouth, we've got Brian Morris, who's a social worker who is just for cancer care. He's an expert in what people are entitled to. You are entitled to benefits. You need to talk to your nurse specialist, talk to your, if you've got a social worker, access to them, do talk to them. Next question, does anyone have any great ideas for the best way to combat fatigue? Yes, again, I think it's a symptom that most people at some point in their disease will develop. Exercise is very, very good. It's not what you'd naturally do when you're tired, but it's a very good way to combat fatigue. There is at the back of the stand, I don't know if they're still here, we have Bournemouth Backs Up, which is Bournemouth After Cancer Survivorship Programme, and that's really is geared towards people who have gone through chemotherapy. Exercise is a very good way of combating some of the side effects of chemotherapy, but it's also very good for fatigue. So I'd recommend that. Am I right for time? Okay, so this is one about risk of infections, which I hope I've answered. Are you more likely to have a cold that hangs on? Yes, so you're more prone to get an infection in the first place, but also it's harder to shake. So on our table, we had quite a lot of discussion about going on holiday and flying, because obviously air is recirculated on a plane. Still do it, you've got to live well with CLL. I always, if people are going away, I ask my patients whether they want some emergency antibiotics to take with them. I think it's a good precaution to do that. Still see a doctor, but it's helpful to have something in case you need it. Is there a link between CLL and psoriasis? Yes, because psoriasis is one of these sort of autoimmune type of problems that you can get in the skin, and as we've seen, because CLL is a cancer that's grown out of the immune system, it can be throw the kilter out of balance, and so you can get some of these problems. Sorry, I haven't brought my glasses, so I'm reading at arm's length. Okay, so last one, is a good one to finish on. So, mention is often made about personalising treatment. Does this mean that each person would have capsules specifically prescribed for that person? If so, what a miracle. Well, I'd agree, but I think what we really mean about personalised medicine is we're going to targeted treatments, so we know these different subtypes, and we're already at the point in CLL, and it's been the first cancer really where we have done targeted treatment, because Renata said very early on, we've moved to specific treatments for particular genetic changes. We're going to see a lot more of that in the years to come, and Renata's going to cover a lot of this in her talk now. So it's a good introduction to Renata, really.